My name is Dr. Shuttle Shah, Chair of the Pediatric Policy Council, and I have the honor of introducing our featured guest, Dr. Julie Morita, and our moderators for this conversation entitled Policies to Advance Children's Health and Equity. Today's event is sponsored by the Pediatric Policy Council, or PPC, which serves as the policy and advocacy voice of academic pediatric medicine on federal issues related to child health. The four member organizations of the PPC are the Association of Medical School Pediatric Department Chairs, the Academic Pediatric Association, the Society for Pediatric Research, and the American Pediatric Society. It has long been known that a significant part of children's health outcomes are socially determined. As pediatricians and researchers, our job is to mitigate these issues for the patients we care for and to better understand the biology of how adverse childhood experiences encountered early in life impart epigenetic influences that can impact health and be transmitted to subsequent generations. However, it is also within our power to advocate and to promote policies which ensure social determinants of health and inequities in child health are alleviated across our communities and across the country. The ongoing COVID pandemic has both drawn attention to these inequalities, but also unfortunately accelerated them. To lead us in a discussion on how to address the uphill battle too many children face, I am fortunate to introduce our moderators. Dr. Steve Aibman is president of the American Pediatric Society and a professor of pediatrics and pulmonary medicine at the University of Colorado School of Medicine. Dr. Tina Cheng is the chair of pediatrics, chief medical officer, and research foundation director at Cincinnati Children's Hospital Medical Center, and a member of the Pediatric Policy Council, representing the Association of Medical School Pediatric Department Chairs. Dr. Stephanie Davis is president of the Society for Pediatric Research, chair and the Charles Everett and Catherine M. Brewer Professor of Pediatrics at the University of North Carolina. Our featured guest is Dr. Julie Morita, Executive Vice President of the Robert Wood Johnson Foundation, the nation's largest private philanthropy dedicated solely to improving the nation's health. Dr. Morita is the former commissioner of the Chicago Department of Public Health, earning that position after previously serving as chief medical officer. She has worked her entire life on the field of health disparities, beginning with her work as a pediatrician in Tucson, Arizona. Most recently, and in a personal capacity, she worked on the Biden-Harris transition team's COVID-19 advisory board. Dr. Morita is speaking with us today in her Robert Wood Johnson Foundation capacity, and so we will keep the discussion focused broadly on policy issues, avoiding discussion of politics and legislation.
First of all, I want to start on behalf of the American Pediatric Society and really all of pediatrics. Shuttle, thank you so much for your hard work leading the council. You know, the PPC has been a wonderful instrument to bring societies together and to weigh in on many of these important issues. So thank you. And it's also a pleasure to hear from Dr. Morita, and thank you for joining us today. And so I think we have many questions. I'm going to start with a fairly general one, and that is children are facing a number of challenges right now, from mental health issues to food insecurity to secure housing and others. But if you had to rank them, what would you say are the top three greatest threats to children's health right now?
Hi, Steve. Thanks for that great question. And thanks to Shuttle for the really warm welcome and nice introduction. I think Shuttle really did an incredible job kind of outlining what are the top priorities and areas of concern given what COVID has really laid out for us. It's just made it so incredibly clear that our health is so inextricably linked to these social determinants of health, to these structural inequities that we have within our nation. And so when I think about the priority areas of concern as it relates to child health, I think about mental health, because what we're seeing play out in our nation is that there's just this increased problem with children and pediatric patients having problems with mental health issues arising as a result of this pandemic. The isolation, the stress the families are under, the poverty, the lack of food, all those kinds of things contribute to the mental health of our children, and that's a major concern. The other issue I alluded to earlier is also the child poverty in general. Because of the economic impacts of COVID, what we've seen is that fewer children have access to good and nutritious food. Housing is an issue, and it's related to the economics of what the pandemic has done, and it's not affected us all equally. And so it's really a matter of looking at those kinds of issues and programs and policies that can actually support our families during this terrible time. I'm heartened to see the American Rescue Plan actually has a lot of provisions that will help improve the economic status of our families so that our children will be healthier, but that still is a primary concern. And then the third issue that I would say is of great concern is immunization coverage levels, because what we've seen happen is parents have been focused on keeping their children safe and out of the healthcare systems. Our routine childhood immunization coverage levels have really dropped off. And as a former medical director for immunizations, I can't help be concerned about dropping immunization coverage levels, which leaves us more susceptible to some of the serious vaccine preventable diseases that we haven't had to contend with recently.
Coronavirus pandemic has brought to the general public's attention the persistence and the magnitude of healthcare disparities, which you spoke of. And we've seen this in the popular media coverage of the disparities in healthcare access, in illness rates, in hospitalization rates, and unfortunately in mortality. And now, of course, vaccine access as well. What do you think is the most effective way to ensure COVID vaccine distribution is as fair and as equitable as possible?
Yeah, it's been really interesting to watch this pandemic play out. I think it's amazing that we actually have 3 vaccines that are approved for our use in our nation. The speed at which the vaccines were made was truly remarkable. But what didn't happen last year to help us prepare for distribution of the vaccine was an infusion of resources and dollars to state and local public health departments, because they are the front lines who are expected to actually coordinate the delivery and the distribution of the vaccine. And so when the initial rollout of the vaccine occurred, emphasis was placed on just getting the vaccine out as quickly as possible, and consideration of who was at greatest risk for disease or more likely to be hospitalized or to die from COVID really wasn't necessarily taken into consideration. And so I think what we saw with the early phases of the rollout was that we were seeing that the communities that were most impacted by COVID are African American, our Latin, Latino communities, our Native American communities, our low-income communities, and our rural communities, which were hit hard, didn't necessarily get the vaccine access that they really needed. And so as a result, over time, what's happened is we're seeing increasing effort on the side of the state and local health departments and the federal government working together to really improve that access. And that means making the vaccines accessible within communities, making sure that the appointments are accessible, not just online, but by telephone, or that there's community workers going out into the community to help people register for the vaccine. That is a huge challenge. And the way the systems were set up initially were inequitable. But what's happening now is there's an infusion of resources that have been coming that have allowed the state and local health departments to really to ramp up their systems. And as a result, vaccine distribution is increasing overall, and it's getting into more of the communities that were hardest hit. So it really requires deliberate attention and concentration on what are the needs of the community, and how do we make sure that their needs are actually being addressed by the systems that we create.
Thanks.
Thank you, Julie. Again, thank you so much for doing this. On behalf of SPR, we're excited to have you participating in this. And thank you, Shuttle, for organizing this. My question really aligns some with what Tina just highlighted. The vaccine hesitancy related to COVID remains really a large obstacle to achieving the threshold for herd immunity. And though a lot of attention has been paid to outreach, there remains a large percentage of the population, estimated as high as 20 to 30%, that may remain unvaccinated. So how do we best assure vaccination rates are at a level to facilitate return to normalcy?
Thanks for that question, Stephanie. That's a really important point that you raised. Part of the solution is really making sure the vaccines are accessible, because while I think there is some distrust of the vaccine in our communities of color and our low-income communities, maybe some of our more conservative communities as well, that there's a distrust of the vaccine. That's based on historic and ongoing mistreatments or experimentation that happened in the past. And I think there's good reasons for there to be this kind of concern about the vaccines. Or not necessarily that there's a good reason to have concerns, but there's good reason to have questions, and for us to have to answer the questions. I think we really have to earn the trust of people who get vaccinated. It's with our childhood vaccines that we do this routinely. We have to really talk through with the parents why the vaccines are important, how safe they are, how effective they are, And we've gotten very used to doing that for the routine childhood vaccines. We need to do that same thing and take the time and energy to talk with our patients, talk with our communities, whether they're African American, Latino, Native American, whether they're conservatives, whether they live in rural communities or have low income. What are the questions that they actually have? And who do they want to hear from? Because I think it's really important. It's not just that we get the information to people, but it's got to come from the trusted messenger. Regardless of who you are or where you live, you want to hear from people that you trust. And sometimes it's your doctor, sometimes it's a neighbor, sometimes it's a faith leader, but it's really understanding who are those trusted messengers and working with them to share the information so we earn the trust of the people that we want to be vaccinated. Unless we do that, we will not have success and we will really struggle. I think what the advantage that we have in terms of the vaccine not all being available at one time, it's given us some time to ramp up these systems to really get into community. And I'm really excited to see some work that's happening both in New Jersey and in Chicago, where I have a line of sight into the work that they're doing, that they're really using and working with community workers to get the information to the people who have questions and concerns and really earning that trust.
So Dr. Morita, Dr. Eggman's going to ask a question, but before we move sort of off the topic of vaccines, you had mentioned specifically the role of a person's individual pediatrician or individual physician being sort of an ideal messenger. But my question or concern is, with a pandemic where vaccinating the greatest number of people in the shortest amount of time is kind of the optimal strategy, how do you go about effectively doing that on a one-on-one basis? Do you pair that with a public health strategy? And if so, what might be the ideal messages to try and reach all people who are vaccine hesitant? Because I think that there seems to be almost a trade-off between the individual counseling, which might be more effective but takes more time, and of course the public health emergency.
I think that it's a combination of both. There has to be, when I think back about my time as in the Chicago Department of Public Health during H1N1, which is a much smaller scale immunization response and a much less bad pandemic. What we saw was that we wanted, in order for us to get the vaccine out most quickly and effectively, we distributed small amounts of vaccine to over 700 different healthcare providers in this city. And then we also stood up some pop-up or mass vaccination clinics. And what we did was we really worked with the healthcare providers to give them the information they actually needed so they could actually talk with the patients that were coming into their offices, because they have that trusted relationship already, giving them what information they needed to actually work with their patients. But we also stood up these mass vaccination clinics for those people who didn't really have a lot of questions, who were comfortable getting the vaccine. And we're seeing that play out also with COVID right now, that not only are healthcare providers getting some vaccine, and it's limited amounts at this point, we're also standing up these clinics so that people that don't have questions, don't have concerns, can run out and get their vaccines. But then those who really want to talk to their healthcare providers, there will be a need to get vaccine into their offices, give them getting the information that they need to actually be able to talk with their patients, educate their patients, support their patients, and do that in a way that kind of optimizes both speed as well as addresses the needs of the patients. I think the other thing that I've seen this, what I would say has been done well because of the pandemic, is because we recognized fairly early that there was this disproportionate impact on communities of color. What we did is we really, and we also know historically that flu vaccine coverage levels have lagged some communities of color as well. Really working with trusted healthcare providers to stand up and get vaccinated very publicly. When the first vaccines were rolling out, providers that were Black, Hispanic, Asian were standing up and getting vaccinated publicly so that people would see them as role models getting vaccinated, and also working with them to do public education, working with them to get webinars and teleconferences out there and actually going out into community to educate. So it's a combination of these kinds of things that need to be stood up and stood up rapidly to really address this urgent need of getting the vaccine out.
Yeah, that's terrific. Can I build on Shettl's question just briefly here, because you mentioned strategies, getting the shots in the arms and the diversity of populations. I was wondering if you could speak a little bit more to that in terms of specific strategies from a public health standpoint. In other words, whether it's rural versus urban, or being ex-Chicagoan, I know how diverse Chicago is. The communities can be quite different, or Chicago versus New York. How do you speak to? How do you really become more effective with the strategies that are needed for the given cultural and community issues that one might face?
So I think the first part of that question really relates to just the how you get where you are locating the vaccine. and how accessible the vaccine actually is. So looking strategically in terms of where are the pockets of high rates of disease, which communities might actually need to have vaccines located within them versus those that might actually be able to drive to them. So really looking at the communities where there's highest rates of disease, locating clinics within those sites, scheduling them so that they are operating before work and after work. They're available on weekends, because we know that some of the communities that have been disproportionately hit hard are those that don't get time off from work to get a vaccine, who might not have paid leave. So I think it's really important to think about those logistics. And the other part of it is then working with community to help them to get access to make the appointments, and then also to answer their questions. And the answering the questions part is really, it's a matter of really using trusted groups. And so I know in many of our states and local communities, what they're doing is working with community groups that are established trusted messengers within community already, and giving them the information to then convey to the community. But it's not just giving information, it's really engaging with the communities and listening to what their questions are, hearing what their needs are, and then responding quickly. So it's not just telling the people information and pushing public service announcements or ad campaigns out. It's really engaging in this dialogue so the questions can be answered in a meaningful way. And it varies, and that's why it's so local. The work has to be done at the local level. And so I was thrilled to see the funding going to state, to local communities, so that we could actually get the information into the right hands and really get the money as deeply within communities as possible.
Yeah, that's a great answer. Thank you. I have another question here that obviously the pandemic's destabilized all of our lives, all aspects of our life, especially the prolonged closure of schools, which is a major factor, of course, contributing to our child mental health crisis. And we're hearing from pediatricians all over that reporting mental health issues are more common than in general practice than even ear infections. There's a shortage of mental health providers nationwide, real workforce issues, which really leads to even longer waiting times, delays in outpatient management, and putting up more burden or more need for general pediatricians to have these skills even. But how do we increase the number of pediatric mental health providers nationwide, eliminate geographic disparities in access, and what role, if any, should telehealth play in the strategy? So many questions in there.
Yes, Steve, that was a loaded question, because you also talked schools as well. So maybe I'll start with the schools then.
Sorry.
No, it's fine. I think they're really important questions and so relevant to our kids. I mean, I think we all know that children learn better when they're in schools, that this internet and teleschool could help and serve as a bit of a bridge when we actually couldn't have people in school settings. But we really want our kids back in school. What I was pleased to see recently was that CDC released some more specific guidance regarding how schools can reopen. And then on top of that, what the federal government is doing is pumping a bunch of money into the school system so that schools themselves can be physically reconfigured to make them safe for children to return. So first of all, CDC made some criteria for these are the different levels of disease activity and what kinds of provisions you have to have in place in school. And then the federal funding is coming to the schools to actually allow them to have decreased numbers of kids in schools, to have the appropriate distancing between kids when they're sitting in desks, to have the appropriate ventilation systems that are in place, and then also supporting additional testing so that we can identify when people do become sick, and then coordination with public health to make sure that when children that are sick get identified or teachers that are sick get identified, the appropriate quarantine and isolation measures can actually occur. So what I've seen happen is this recognition of there needed to be more specific guidance for school systems, and then the dollars are now starting to flow to the schools to actually be able to prepare them to house children safely. So the hope is that we'll have all our kids back in school in the near future, which would be fantastic. But the question that you asked, the follow-up questions that you were asking related to mental health are also really big issues. And I think there's a lot of work that needs to be done. At baseline, we didn't necessarily have a strong mental health system for our kids. And so what COVID has done is just underscore the need and also highlight the fact that we need to really think of creatively of what we can do to enhance the systems. And so part of it is looking at ways that we can actually increase services in maybe non-clinical settings. One of the Robert Wood Johnson Foundation is really focused on aligning social services public health and healthcare systems, recognizing that when we all work together, we can actually address these social determinants of health and some of the major inequities that our population has been facing, our nation has been facing. And so it's whether it's increasing access to mental health services in school settings or in social service agencies, so that when other services are being provided, the mental health services can be made available. The other thing that I think is probably you all know better than I know is the reimbursement issues as it relates to mental health. Reimbursement is not necessarily sufficient for meeting the costs associated with provision of mental health services. And so we really need to take a hard look at how those services are reimbursed to make sure that they're reimbursed adequately and there's more incentive for people to be providing these services and that our patients can actually access them. And then I think that there's been a lot of innovation that's been done in terms of telehealth and other innovative ways of engaging with adolescents with mental health type of services, whether it's through online type of activities or texting or that kind of approach. But those successes really need to be evaluated. I should say those interventions need to be evaluated to make sure that they are successful, and then to understand what areas need to be improved so that we can really improve the mental health services that are available quantity-wise, but then also quality-wise, because unless we do that, we are not going to meet the needs of our pediatric populations.
Great, thank you so much.
Thanks so much. You mentioned poverty being one of the big three areas that we really need to focus on, and food insecurity is often part of that, and it's risen dramatically with the loss of many school nutrition programs and job losses for certain sectors of the workforce. In an effort to ameliorate the burden of food insecurity, SNAP benefits were increased by 15%. Is this the right percentage, or is this enough? And what other actions could be taken to ameliorate food insecurity for children, not just during the pandemic, but beyond?
Right, food insecurity is just an enormous problem that we're facing. You know, there are estimates of about 50 million people being food insecure in 2020. And that 17 million of those individuals were actually children. That's just, it's not acceptable for a nation with our wealth to be able to have that many people that are food insecure. And we know as pediatricians what the impact of poor nutrition is, or inadequate or insufficient nutrition is to our kids and their health and well-being. So there really needs to be more that is done. I almost feel like I'm an advertisement for the American Rescue Plan, but I do feel like there were some really good elements within the American Rescue Plan that actually support and address some of the food insecurity issues. So the SNAP benefits were actually increased temporarily to 15%, but those expire. The benefits expire in September. So while they'll help us right now, that won't necessarily help us for the long run. And we actually think at RWJF that a 20% increase is actually what would be most beneficial for the long run. So 15% is great and it's good to have, but it needs to be extended beyond just the end of the pandemic and then also increase to 20%. The other thing is there's other provisions that are also in place and other supports that are in place, like WIC. So we know that 6.3 million people are enrolled in WIC in the nation, and about half of our children are actually, infants are actually enrolled in WIC in our nation. So those programs need to continue and need to be supported so we actually have as many children as possible benefiting from them. And then, as you pointed out, school nutrition as well. The American Rescue Plan includes support for the school nutrition programs, but that will also expire before the end of this year, and we need to look at that for the long-term benefit as well.
So, Dr. Morita, I want to kind of build a little on that, because you mentioned that 20% is sort of the recommended percentage of increase in SNAP as opposed to 15%. But then is that a percentage that should exist indefinitely, or at what periods should we be evaluating whether that number actually should be adjusted, specifically if it should be adjusted even further upward to meet the needs of children?
I think that just your question, Shuttle, is great, because I think what it does is it really points out the need for ongoing evaluation and assessment. So we say that 15% is not, we'd like it really to be 20% based on studies that we have done or we've supported. And so we would promote that. But I also feel like once you get to 20%, it's really a matter of looking at what is the health benefit of that, what is the cost, what is the health benefit of it, and then looking at whether or not that should be increased or decreased and how long should it be sustained. But at this point, that based on the information that we have right now, I would say that 20% is where we should be heading.
No, I only bring it up because when we talk about the importance of early nutrition, right, the outcomes can be anything you choose, right? It can be 6 months, it could be 1 year. But when we talk about the importance of early nutrition, particularly in the first 1,000 days, we're talking about potential benefits throughout the life course. So the question then, we sort of have to ask ourselves, I guess, almost not just as a pediatric community, but almost as a society, when we provide these benefits, why are we really providing them? Are we providing them to alleviate the short-term burden of hunger? Or are we really doing it because we're investing in growing brains and growing children's potential? Which is why I asked, because it seems like a better way to, and this is my bias, I guess, a better way to go would be to evaluate these really over, into early adulthood.
Yeah, the long-term benefits of good nutrition, I think is something worth exploring. I think that's a great point.
Thanks, Julie. I want to ask a little bit about Medicaid. The percentage of uninsured children had steadily decreased from 2008 to 2016, but has started to rebound again. And what do you think the best ways are to ensure Medicaid reaches its full potential of providing access to care for all eligible children?
So we recognize that when adults are insured, children are insured, and vice versa, that it benefits both ways. So when we insure kids, adults are better insured. So our ultimate goal is for there to be universal, affordable health care for all, and that would definitely benefit children overall. What I would say is that, again, with the American Rescue Plan for right now, what's happened is that there's an extended COBRA benefits, so that individuals who lose their jobs can maintain their COBRA benefits with much less cost burden on themselves, which will help protect families, help protect kids in general. We also know that there were some significant improvements in subsidies for the marketplace insurance to cover families and children as well that were impacted by the pandemic. And again, these are short-term benefits. I think they go through for 2 years, so they last longer than the nutrition benefits, which is a good thing, but they're still not extending beyond the 2-year period of time. On top of that, there's been some good incentives for Medicaid expansion. So there's 12 states that actually have not expanded Medicaid, and we know the benefits of Medicaid expansion. And so there's some good incentives built into the American Rescue Plan that would encourage some of these states to actually expand Medicaid, which would improve access to insurance for children and adults as well. And I think those kinds there's the beautiful thing too about one of the provisions that's within the American Rescue Plan that I'm really excited to see is that there's an option for states to actually expand their Medicaid coverage for pregnant women to 12 months postpartum instead of cutting it off at 3 months, which can make a big difference in terms of child health, infant outcomes, as well as maternal outcomes, which are just so closely linked. And so I think that those kinds of provisions are all in place, should last out for 2 years. But again, it's a matter of us having this conversation about how long do we support these, and should we support them beyond just the 2 years? And RWJF believes strongly that these should be extended beyond just the 2-year period that they're covered right now.
Dr. Morita, though, just to pick up a little bit again on that thread, even if Medicaid in the 12 states were to be expanded, we all know as pediatricians, there's a difference between expansion and increasing eligibility, and then the brass tacks of actual enrollment. So I was wondering what your thoughts are, both at the federal level and then in individual states. There's ongoing debate right now about continuously enrolling children who are Medicaid eligible from birth through the first 1,000 days of life, so the first 3 years. So, taking advantage of your expertise, what are your thoughts specifically on that proposal and its potential benefits?
I experienced this firsthand in Chicago, working in public health, where we saw these kids that were coming in and out of Medicaid coverage because of enrollment challenges. They would be eligible, they wouldn't be eligible, they'd have to re-enroll, or even if they didn't lose eligibility, they just have to re-enroll and they would lose coverage. So there's got to be systems built and the policies have to be established in ways that actually help people stay enrolled and stay covered, because when people drop in and out like that, that's when we see these major problems. So I would say you're right, it's not just a matter of making sure that the Medicaid is expanded or that it's available, but it's also a matter of supporting the populations to stay enrolled. And some of it can be done at a systems level. If the policies are made so that you don't have to re-enroll as frequently, or if you're not to be dropped automatically, those kinds of system changes can make a big difference. And then on top of that, there does need to be ongoing work to really engage with communities to continue to help people to enroll, to know that they're eligible, and to support them as they are eligible. That's where I feel like some of the work that's happening with the vaccine work, getting into communities, to engage with community, establish trusted relationships, is really those kinds of community organizations and those kind of partnerships can actually help to build on other health-related activities like enrollment in Medicaid or vaccination, childhood vaccines outside of COVID. There's all these kinds of relationships can actually be relied upon to actually support improved health overall. In fact, the RWJF is actually supporting a project that's focused on grassroots work to promote COVID vaccine, but it's building on the infrastructure for Get Out the Count, Get Out the Vote, and Enroll America, because there are these infrastructures that are in place already, and they have trusted places within community, and then leveraging that for vaccine campaigns can be really effective. And so we're really hopeful that will actually help us with some of our vaccine trust issues as well.
Great, very good. I wanted to ask you more about paid family leave policies as well, and that 9 states and District of Columbia have enacted these paid family leave policies. The policies in these states will provide a natural laboratory to answer questions about the population health benefits and economic impact of such policies. What are the most pressing but unanswered questions about a national policy, paid family leave policy?
Yeah, I think we know some of the benefits of family paid leave, that in terms of maternal mental health, postpartum. We also know that it helps with immunization rates and breastfeeding rates among babies when they're, if parents have paid leave. So we know there are some true benefits, but there are many questions that are unanswered. And it's things like, what is the paid family paid leave? How does that affect paternal health? Does it make a difference in terms of paternal health? The other question, it relates to things like birth weight and preterm birth. And those kinds of factors are also things that we don't really have good information about. So there's a lot of unanswered questions that we could really start looking into in terms of the benefits of it. I think we also don't know like which of the family paid leave policies are most effective. What is the duration that's optimal? How much funding or how much pay are people given during their leave? Those kinds of factors. We'd like to know what those kinds of things do to the impact on health. So I think, as you pointed out, we know that paid family leave is a very important thing, and it can make a big difference in many ways, but there are probably some benefits that we don't even realize, and it'd be great to be able to know what those are as well.
Great, thank you. Do you have comments about the international lessons learned? Many countries seem to be ahead of the curve for where the United States has been. What lessons are take-home lessons for benefits along those lines?
I think that's a great point, that I think there actually should be some research done in terms of the European type of approaches to paid family leave, because they certainly have much more generous packages. Even just across the border to the north of us, they have a much more generous package for family paid leave. And I think there's some lessons that could be learned. So we don't have to start from scratch. We could look globally and get a sense of what's happening in other countries to really inform what it is, types of policies that we implement to make sure that they're most effective and they have the best impact overall.
Great, thank you.
Thanks.
Yeah, Dr. Morita, I think Dr. Morita, I also think it's very important, because while we're still on the topic of paid family leave, and also to kind of dovetail that a little bit into your comments about expanding postpartum Medicaid coverage, I would be amiss if I didn't make a shameless plug so that the cost effectiveness of these programs also include the impact on potential subsequent children. Right, we know that access to care, whether it's through postpartum Medicaid continual coverage or whether it's through potentially the mechanism of paid family leave, really does have the ability to lengthen to more ideal circumstances the interpregnancy interval. And we know that shortened interpregnancy intervals are associated with stillbirth and premature birth. So, getting the rare opportunity to speak to someone of power, I would say that please make sure that as these things are rolled out, and when we look at these cost effectiveness things, we look at them more globally. Because as a neonatologist, we all know that, the best premature birth is the one that you can prevent.
Yeah, pediatric care is family care, and family care requires great pediatric care. So switching gears a little bit to a topic that I know that you've really been a leader in is around tobacco. And as commissioner in Chicago, you were a driving force in pushing for Tobacco 21, which raised the age to purchase tobacco products to 21 years. And that policy subsequently became federal law in 2019. After a big rise in teen vaping in 2015 to 2018, rates subsequently declined amidst FDA regulatory actions to review products for public health impact prior to sale and local and state flavor bans. However, we know that in 2020, rates have kind of plateaued, and with almost a third of 10th to 12th graders reporting vaping nicotine in the past 12 months, which is really incredible. In addition, we know that menthol cigarettes remain the only flavored combustible cigarettes still on the market, despite having well-documented impact on racial health disparities. If you put on your commissioner hat, what steps would you take to further reduce tobacco use to really protect our kids?
Yeah, that's a great question, Tina. I think commercial tobacco is such a major health risk, health challenge. We know the damage that it does in a lifetime when people are smoking. And we also know that young people get addicted to tobacco, that's when they become lifelong users. And so it's in our best interest to really do everything possible to prevent those addictions from actually occurring. What I would say is a top priority is really a matter of, for commercial tobacco, is elimination and banning menthol and other flavored tobacco products. So menthol cigarettes and other flavored tobacco products. There's been some progress that's been made, but it's been a little bit piecemeal and patchwork throughout the nation in terms of the bans on flavored tobacco, and some of them don't include menthol. So I really do underscore the importance of addressing menthol cigarettes in particular, because even in Chicago, my home city, they were able to enact a flavored tobacco ban, but it excluded menthol. And as you pointed out, menthol has really high percentage of the African Americans who smoke and LGBTQ that smoke are actually using menthol products. And it's because young people get addicted at an early age because the menthol masks the bitterness of traditional tobacco flavors. And so they get addicted at a young age because it's easier to use the menthol and it's smoother. And then they have a really hard time breaking the habit. And so it's really, from our perspective at RWJF and most of the advocacy groups that are focusing on tobacco use in general are focusing on elimination of menthol and other flavored tobacco products just to prevent youth from getting addicted to begin with.
Thank you, Julie. I'm now going to move a little bit to just health equity and the COVID pandemic, which has certainly illuminated inequities faced by communities, what we see in our healthcare system, and specifically by communities of color. What changes need to be made moving forward to advance health equity and ensure that these communities are no longer more vulnerable to health crisis simply because of their race?
I think that's a great question, Stephanie. I think that when we look back at this, I'm not looking back on the pandemic because it's clearly not over yet, but there's what I would say has been revealed in the past year so far is that there's these structural inequities that really contributed to the disproportionate impact of COVID on our communities of color, our low-income frontline essential workers. Those groups were really hit hard by this pandemic. And the reason that they were hit so hard was because they didn't have the ability to protect themselves from the pandemic itself. They didn't have paid leave. They didn't have good jobs with good pay. They lived in crowded housing situations or live in crowded housing situations so that the disease was actually able to spread more quickly and more easily. There's these kinds of structural inequities that are in place. And COVID has made that clear that those kinds of things really impact health overall. And not only do they impact the individuals that are experiencing those challenges, but they also impact everybody else around them because they get sick. The pandemic perpetuates and continues. We just can't get things under control. And so it's in our best interest to address these structural problems up front so that for the long term, at baseline after we get out of this pandemic. And then before the next pandemic, we are in a much better place, and these same groups aren't left more vulnerable, and we as a nation aren't left more vulnerable. So I think that there's a real lessons that have been learned throughout this pandemic. And I'm hopeful that we will take the information that we've learned so far and really have it inform stronger, better policies that allow us all to live more healthy lives as we move forward.
Yeah, can I ask a question to follow up on Stephanie's, and that is, we're all involved with academic health centers, and if nothing else, one of the positives of COVID is there's a whole generation of folks who now really interested for various reasons, whether it's anti-racism, the health disparities, the dynamics of impacting broad populations. No new generation coming up that'll be revved up, I think, to get engaged in the kind of career that you've had. And I'm wondering what recommendations or what thoughts you had, what you have about how we could help feed that forward in terms of successful careers, but also having a diverse workforce.
Yeah, that's such a great question, Steve. I think that it's funny, there's this quote, I think it's often attributed to Rahm Emanuel, but I think it was actually a Winston Churchill about never let a good crisis go to waste. With every good crisis, there's an opportunity. And I feel like that this crisis has done that. The opportunity is this awakening to the need to look at these structural inequities and the impact of policy. So the fact that you all do the work that you're doing on policy and focusing on policy, that's where these system changes really can occur. And then including your medical students, your residents, in conversations, in the work related to advocacy and policy is so important, because then it doesn't have to be all people like me who are just focusing on this kind of work all the time, but having clinicians who are front lines experiencing what's happening. You inform meaningful policy that really can make a difference, because sitting where I sit and I'm not taking care of patients, I lose that perspective. So having clinicians that have your knowledge and your perspective is really valuable. So I don't think it has to be an either you are a clinician or you're a policy person that works on policy. I think it really should be a blend, some that do policy, some that do clinical work, but then there's got to be some people who are doing a bit of both, because the clinical perspective that you bring to the conversations is so incredibly valuable.
Well, thank you. Along those lines, we hear all the time that the public mistrust of science most broadly, again, unmasked by the COVID and the vaccine issues and many political issues. But the idea of leading with science, of course, ends up being crucial, and then communicating that science. So I'm wondering what kind of gaps or how to really achieve that. You mentioned that you don't necessarily have to be public health guru to necessarily be engaged in such issues in our own ways, in our own fashion. But this concept of leading with science to help reinvigorate public trust, how could we think about that from an academic health center perspective, let's say?
Yeah, I have a couple of thoughts about that, because I think leading with science is essential. I mean, I think when I was able to participate in the Biden transition team task force, and what we were charged with was lead with science and ground in equity. We really need to use those things as we look at the work that we're doing and the recommendations that we actually made. So leading with science is so important. But as we communicate that science to the public, the power of the story is unbelievable in terms of what does that science mean in terms of playing out in the real world. And so clinicians who have those real world experiences can lift up reasons why something is science, why it is important, what the science actually means and translates into practice. And I think that's really, really important. But I also feel like the other part that's really important is not just to have the story, but also to be able to acknowledge that there's some things we just don't know, that we'll lead with science, but the science is not always precise, and it evolves. And I think that's where some people had problems last year, was that with an emerging disease, that what we know about the disease will change over time. And so our recommendations will change over time, but acknowledging that up front is really, really important, so that people don't hang on every word and say, wait a second, they just said that last week. But that's what happens when you have an emerging disease. You learn more and you modify and you adjust. But if we set the stage for that and set that expectation up front, people don't have that same kind of distrust or what's people are being of the science, because they're anticipating that things might actually change.
Great.
So Dr. Morita, I want to pivot a little bit back towards mental health. one of the things that has been occurring in different states, my home state of New York has had a project called Project Teach. Last year, Virginia had a very similar project in which they basically invested dollars in training general pediatricians to really be able to address a significant number of mental health issues that are, basically that are coming to them in practice. On the one hand, you sort of love that idea because it increases access across the board with a local healthcare provider, someone like we talked about who has earned that trust, particularly with someone like an adolescent. But then on the other hand, I think that there's also the concern that if that becomes widespread, there's also concern that that might devalue the role of the actual child mental health psychiatrist or the actual subspecialist. How do you balance both of those, knowing that we need to make sure that we still have a lot of child mental health specialists because not everything's going to be able to be handled in the outpatient setting?
Yeah, so when you asked that question, I think back about my time in practice in Tucson as a general pediatrician, and I did not feel equipped to deal with most mental health issues of my patients. And I would have loved to have been able to rely or learn more, have an opportunity to educate myself and be able to manage some of the more minor mental health issues that pediatric patients experience. But I would not have wanted to take on some of the more difficult or more challenging or difficult to treat type of problems. And so I think it really does, there is a need for primary care pediatricians to be able to get more skills and acquire more knowledge in how to manage some of the easier, more straightforward type of mental health issues. But I also feel like there's always going to be a need for these subspecialty training that gets into the more advanced and more complicated type of issues. The Robert Wood Johnson Foundation has funded an ECHO project in the past, which actually helped link specialty care to more rural communities through teleconferences and webinars and that kind of thing, so that primary care providers could actually be partnered with specialists to learn and acquire more skills to learn how to manage, but also be able to tap in and rely on those subspecialists to really help them deal with the more complicated or challenging patients if they weren't able to get their patients to the subspecialists. So I think there's got to be this marriage of increasing capacity and skills of the primary care providers, but also increasing the ability for there to be this interplay between them, because I think there is not going to be an ongoing need for this subspecialty care.
And then I think the other part of mental health is how do we go even further upstream? I think in our hospitals, we are seeing the kids coming in crisis, and obviously we want to prevent them from coming in crisis, but we also want to prevent them from having the mental health problem in the first place. So thoughts on how to go even further upstream?
Well, Tina, I think it really goes back to these root causes, the social determinants of health, and really addressing the structural inequities that leave people with food insecurity or inadequate housing or insufficient resources just to survive. Those are the ACEs that we're talking about, the things that contribute at early ages that lead to people having poorer health in the long run, including mental health. And I think when we start, that's the way RWJF is thinking about it as well, is that when we look at these upstream factors, and if we can address the inequities and the policies that are in place that really don't allow everyone or don't protect everyone or allow everyone to protect themselves, if we address those upstream factors, we will address both physical and mental health as well.
Julie, I just want to, as we're talking about mental health issues, specifically focus a little bit on school reopenings. And certainly that's been a major issue. And we've seen in North Carolina, and I think across the United States, significant concerns with children who are able to do online schooling and others who couldn't even access it because of internet issues, et cetera. So we're just seeing a widening gap in education. So understanding certainly every school district is different. Could you comment on that, and how would you think about, as we move forward, reopening schools?
That's a great point, Stephanie. I think that the gap that we saw played out clearly. The challenges that we saw related to who was getting sick and most likely to end up hospitalized and dying also impacted those same communities were the ones that actually had less access to consistent broadband, fast speed, high-speed internet so that these kids weren't able to actually access the online learning that was available to them. And so we really need to think about improving access to broadband in general and make that more consistent. That's basically, I feel like that's kind of a social determinant of health at this point, that we really need to make sure that there's high-speed internet access throughout the nation so that everybody can benefit from it, because we are so dependent on it. And it's so valuable to have. But in the meantime, I think what I'm pleased to see is that the American Rescue Plan really does pump a lot of dollars into the reopening of schools. There's billions of dollars that have been funneling to schools so they can set up the school so that the majority of kids can be back in the school set, because that's where optimal learning. Because even if you have high-speed internet access, optimal learning doesn't occur at home. Last spring, I had my 17-year-old son was at home doing his senior year in high school from home. And I would say that was a pretty interesting experience. And though he's a hard worker and he was fairly motivated and we were here supporting him, it was not an optimal situation. So even for those who have high-speed internet, that kind of homeschooling is not optimal. So I think it's really a matter of the key thing, and I agree with the current administration, get the schools open so we can get all of our kids back into school, and the dollars are now starting to flow so they will be physically safe enough, and then there'll be the systems in place to support them if cases are identified and they can respond quickly. Because, throughout last year, we saw that it was a natural experiment. Some schools were actually open the whole time, and their disease transmission within the school setting was fairly limited, but these were schools that actually kids were able to get a mask and wear a mask. They were able to sit 6 feet apart. They had good ventilation. We need to make sure that all of our schools are set up in that same way, that so all of our students can be back in those settings so that we make up for this year of lost education.
And then if we could pivot one last time to tobacco, which I know is an issue that's very close to your heart. One of the issues that local pediatricians and local advocates sometimes encounter is if something can't be done at the state level, is to look at a big city like Chicago or New York. And if it's not feasible there, to even go to a county or even to a town and try and get some local ordinances passed. But sometimes the sort of the pushback you get is, well, we don't want to do it in this town because people can then just go right over to the next town and have access to vaping flavored tobacco products or menthol related products, or whatever the newest form of nicotine vector is. So if I could ask you to advise those pediatricians who are talking to a local town board and have a skeptical town board member say, well, why should we do this here when they can drive 5 miles into the next town and still have access to these products? How would you advise them from a public health standpoint?
That was always the argument that we experienced in Chicago whenever we tried to tobacco 21 or flavored tobacco bans, that we always would hear, oh, but people can just drive over to the neighboring county or city to actually get the products. And there may be some of that actually occurs, but if our focus is primarily on youth, and they don't all drive and they don't all have access to a vehicle easily. And so I think there might be some bleeding over that goes into other communities to purchase products, but I don't think it's significant enough not to make the effort and to do the right thing. I also feel like it's very contagious. So when Chicago started implementing some of these tobacco policies to ban sales to youth, ban flavored tobacco products, that kind of thing, it bled out into the rest of the state. And so it started within Chicago, and then other jurisdictions jumped on board. And so it didn't take very long, and then became statewide soon after. So I feel like part of it is you demonstrate that it can be done. There might be some of that spillover, but that's not a reason not to do the policy, because it's the right thing to do.
Wow. I really want to thank you, Dr. Morita, for spending this hour with us, for giving us the benefit of your expertise and of your experience. I want to thank Dr. Adman from the American Pediatric Society, Dr. Davis from the Society of Pediatric Research, and Dr. Cheng from the Association of Medical School Pediatric Department Chairs. I think this is really going to be a valuable program for a lot of pediatricians who want to get more familiar with these issues, who want some advice, and also who just want to understand the importance that social determinants of health play in a child's life course. As we've touched upon many, many times, broadband access is now essentially becoming a social determinant of health, and that the COVID pandemic has really laid bare the importance of social determinants of health. And I really thank you for not just arming us with information, but also for being an example of how one can take policy and advocacy and really make that their career. Because as academic pediatricians, I think we focus a lot on what's going on in the lab or in the clinic, or and sometimes don't understand that there really is a role to make policy a major part of your academic portfolio, and then also to really blend the two, like you said, to take the clinical experience that you have and sort of overlay that by using stories from your clinical experience to really drive home the statistics that sort of underlie evidence-based policy. So I want to thank everyone for taking the time. I really want to thank you so much for sharing this hour with your fellow pediatricians. You've definitely been amongst your tribe for this past hour.
Yeah, you're a tough crowd, lots of difficult questions. So I appreciate having the opportunity. I was challenged. I hope you could tell I was challenged.
Thank you so much. That was fantastic.
We appreciate your leadership, and we appreciate the leadership of Robert Wood Johnson Foundation as well.
Yeah, thank you so much. It was a pleasure working with you all.
And I don't know if Karen is there, but Karen, thank you again for making Dr. Morita available, for looking over the questions.